Hi, folks. Dr. Ditchek, how are you? It's Monday early evening. Just checking in with you on our educational forum. Took the weekend off. I hope everybody had a good weekend. It was Shabbos Nachum. It was very enjoyable. The weather was great. Um, I wanted to talk. We've been getting a lot of phone calls about the school reopenings and guidance about that. Many physicians throughout all communities have been advising schools, and as schools have been turning to physicians for advice on how to best open the schools. And I think all of us agree that it's very important that we find a mechanism for the schools to be reopened in the fall safely, safe for the teachers, safe for the kids, and safe for the families that send their kids to school. It's such a critical part of childhood and a critical part of normal parenting, so parents can be able to work freely and get their lives back together. But it's going to require cooperation by the parents and the families. I want to speak to that today because before the weekend, the New York City Department of Education, which many of the parochial schools here in the New York area have to follow much of their guidelines because they get funding from the Department of Education for certain parts of their programs. So the Department of Education here in New York, which is responsible for the public schools, put out some guidelines talking about what the school classroom might look like in terms of what if the infections rates start to regain speed again in the fall or early winter. And the Department of Education spoke to specific circumstances. For instance, if a case of COVID is diagnosed in any single classroom, because the classroom is considered a close cohort, a group of cohort, in other words, people who are together for a period of time, that those children in that classroom would be required to go into a 14-day quarantine period at home if one or two cases occurs within any single classroom. What happens if more cases occur? If there's a case in classroom A and a case then down the hall in classroom B, well, the school once again will make those two classrooms, a group of kids in each classroom, go into quarantine at home. However, if there's multiple classes involved where they can establish tracing and contact, the school might close completely for a period of 4 to 7 days to quote clean the school and work with the New York City contact tracing program, which will be in effect and is in effect right now. So one classroom will result in a quarantine of 14 days for the children in that classroom. If two classrooms are involved, it will result in both classrooms being quarantined, obviously, but the possibility of the entire school being closed down for a period of days. If many cases occur or multiple cases occur across multiple classrooms, then the entire school will be closed down for at least a period of 14 days, according to the Department of Education guidelines here in New York City. Governor Cuomo added that for any particular region, if the infection rate within certain regions of the state is greater than 9%, then schools would be closed completely. This is where the battle is going on between the state and cities that we're in the middle of. In New York City, all staff will be encouraged to get tested prior to the beginning of school. Shortly before the beginning of school, students will be encouraged but not required to be tested. And schools are going to rely on self-reporting by those teachers and parents, whether their child or they were COVID positive. So the key to this process being successful is the parental cooperation. Many of the school nurses that I've been speaking to and other physicians have been speaking to have been quite concerned because in general, what happens in many schools is that when a child is sick in the morning, parents are often anxious to get their kids to school. Sometimes the child is anxious to get to school for a project or for a trip. And a parent will give antipyretics or medication like Tylenol or Motrin to lower fever, and then the kid shows up in the nurse's office or in the school office 3 hours later with fever, headache, and not feeling well. If you do that with COVID, if parents cheat and send their kids sick, and that kid turns out to have a COVID infection, that child risks, or that parent risks shutting down the entire school potentially. So it is extremely important that we as parents retrain ourselves not to do foolish things like that. If we send our child to school sick and it turns out to be COVID, it can lead to a closure, which will have implications for entire communities. And I encourage everybody to think long and hard about that because we have a responsibility not only to our children, but to each other. And that responsibility involves cooperating with the schools, cooperating with the tracing and tracking programs within our community so we can identify exposures. Today in my office, we had a positive. It's Monday already. We had our first positive today. The case was reported to the appropriate tracking and tracing program. The family involved is now getting tested and notifying their family members of a new positive right here in our community. So it's important that people cooperate. I want to give you an example of how hard these things can be. The CDC reported over the weekend of a report on a very large outbreak in a summer camp in Georgia. It was, I think, a YWCA. And that summer camp started towards the end of June. It ran for a total of 6 days before it had to be shut down by the local health department. What happened there? Several campers, they did put in a pre-screening program, as most of the camps did. Pre-testing, individuals had to get tested before they showed up at camp. Well, within 6 days, they had multiple cases of COVID and decided to shut the camp. How many campers were there? According to the CDC report, there were 344 campers in the camp, and within a period of about 2 to 3 weeks post-camp, 260 of the 344 campers were COVID positive. 51 of the children, of the 100 children who were 6 to 10 years old were positive. And on the report, 74% of the children who were COVID positive actually experienced symptoms like scratchy throat, sore throat, fever, headache, and cough. So the CDC reviewed why that happened. They felt that in the camp setting, a lot of kids were sleeping together in large cohorts or in bunks. They felt there was minimal air circulation within those bunks and dining rooms. And because of add to that, the amount of singing and cheering that typically goes on in normal summer camps. So this was a case report reviewed by the CDC for the benefit of us learning. But the lesson is COVID is very contagious. And as Dr. Burke said yesterday, that the disease is very widespread now throughout the United States, unfortunately, including the rural areas of the United States, which were spared previously. And those are particularly of concern because the hospital systems in those areas are not very large, or not a lot of ICU care available there. Unfortunately, the recent numbers have been revised up that there unfortunately will be about 170,000 deaths here in the United States by August 22nd or 23rd, and that's an astronomically high number and very, very tragic. And unfortunately, other than certain areas like here in the Northeast, the disease is very widespread right now and growing. I want to talk a little bit about something I've spoken about before, the cardiac issues of COVID. I know I'm focusing on that because it's so important, especially in adults. We reviewed yesterday on the research call that I'm part of with my working group some of the cardiac issues, and it appears that still the number one risk factor, comorbidity with COVID above a certain age group, and that age group could be above 40, by the way, is hypertension. Number two appears to be diabetes, specifically type 2 diabetics when it's accompanied with obesity, general coronary artery disease that comes from high cholesterol, and most importantly, the cardiologist who spoke to the group spoke about this is not direct injury to the heart from the virus. This is inflammation of the heart, both the muscle of the heart and the blood vessels of the heart. And what was fascinating is that when they looked at the culprit lesions, when somebody shows up suspected of having a heart attack in the emergency room and they have an angiogram, there's what we call a culprit lesion or a blockage, which they can go after and either open up with a stent or do surgery to open up that lesion. So normally there's no culprit lesion in a normal circumstance in about 10 to 15% of individuals who show up having a heart attack. But during the COVID review on the myocardial infarctions or heart attacks, almost 40% of individuals who had heart attacks during COVID, there was no culprit lesion. So clearly, COVID causes an inflammation of the blood vessels, which can cause general sludging and blockage of those critical blood vessels. So you don't have to have an exact obstruction to have a heart attack when you're somebody in the high risk group with COVID. He also spoke very interestingly, a study in Hong Kong. They looked at the end of January when COVID was more prominent in that part of the world, and the typical response time from the time a patient gets symptoms to ending up in the hospital for acute care with a heart attack went from 80 minutes to 300 minutes pre-COVID, post-COVID. In other words, before COVID, it took 80 minutes for anybody to show up in the hospital to get critical care, and post-COVID, it took 300 minutes, mostly because people were apprehensive to go to the hospital and they would be in denial that they were having a heart attack. In addition to that, to show that the time to care with cardiac issues since this pandemic has gotten worse, Italy published their out-of-hospital cardiac arrest numbers during the peak. So they looked, Italy was raging with COVID in February of 2020, a few months ago. They compared it to last February, 2019, and they found a 58% increase in out-of-hospital cardiac arrests during February of 2020 versus February of 2019. And what that means is that people were waiting too long to seek care when they were having a heart attack. And we saw that here in the United States as well. So the lesson of the day is, if God forbid you think you're having cardiac symptoms, and part of COVID is chest pain with the cough and the pneumonia, don't hesitate to go to an emergency room. You must seek immediate care. You could be having a heart attack, or even if you have COVID, you're at much greater risk of having a heart attack if you fit into the high risk groups of folks with hypertension, diabetes, coronary artery disease, obesity, or high cholesterol. So that's the lesson of the day. I think we'll continue this tomorrow. We got a lot of information in today about the schools and about the cardiac issues related to COVID, and I hope to meet with you guys tomorrow again. Take care.